Hi everyone, my name is Jacob Lebin. I am an emergency physician in the Department of Emergency Medicine at the University of Colorado, and I'm also a medical toxicologist at the Rocky Mountain Poison Center and Drug Safety, and today I'm going to be discussing radiation emergencies. I've set out the following learning objectives for the brief talk. I know that radiation exposure is an uncommon topic to discuss, so we're going to start with the basics. So what is radiation? At its core, radiation is energy given off by matter in the form of waves or high-speed particles. There are two kinds of radiation, non-ionizing radiation and ionizing radiation. As clinicians, we care about ionizing radiation as this can result in cellular damage. Ionizing radiation is a form of energy that acts by removing electrons from atoms and molecules of materials that include air, water, and living tissue. A familiar example of ionizing radiation is that of X-rays, which can penetrate our body and reveal pictures of our bones. We say that X-rays are ionizing, meaning that they have the unique capability to remove electrons from atoms and molecules in the matter through which they pass. Ionizing activity can disrupt and damage DNA. Depending on the magnitude of the dose, organs exposed, and the type of radiation, cellular damage can cause acute illness, increase the risk of developing cancer, or both. There are several types of ionizing radiation which differ in their size, energy penetration, and damage potential. Alpha particles are positively charged and made up of 2 protons and 2 neutrons from the atom's nucleus. Alpha particles come from the decay of the heaviest radioactive elements such as uranium, radium, and polonium. Even though alpha particles are very energetic, they are so heavy that they use up their energy over short distances and are unable to travel very far from their source. The health effect from exposure to alpha particles depends greatly on how a person is exposed. Alpha particles lack the energy to penetrate even the outer layer of the skin, so exposure to the outside of the body is not a major concern. Inside the body, however, they can be very harmful. If alpha emitters are inhaled, swallowed, or get into the body through a cut, the alpha particles can damage sensitive living tissue. Beta particles are small, fast-moving particles with a negative electrical charge. These particles are emitted by certain unstable atoms such as hydrogen-3 or tritium, carbon-14 or strontium-90. Beta particles are more penetrating than alpha particles, but are less damaging to living tissue and DNA because their ionizations they produce are more widely spaced. They travel farther in the air than alpha particles, but can be stopped by a layer of clothing or by a thin layer of substance such as aluminum. Some beta particles are capable of penetrating the skin and causing damage such as skin burns. However, as with alpha emitters, beta emitters are most hazardous when they are inhaled or swallowed. Finally, gamma rays are weightless packets of energy called photons. Unlike alpha or beta particles, which have both energy and mass, gamma rays are pure energy. Gamma rays are similar to visible light, but they have a much higher energy. Gamma rays are often emitted along with alpha or beta particles during radioactive decay. Gamma rays are a radiation hazard for the entire body. They can easily penetrate barriers that can stop alpha and beta particles, such as skin and clothing. Gamma rays also have much greater penetrating power than several inches of dense material like lead, or even a few feet of concrete may be required to stop them. Gamma rays can pass completely through the human body. As they pass, they cause ionizations that damage tissue and DNA. There are 2 broad categories of radiation contact: exposure and contamination. These are really important to understand because they impact medical management and risk to healthcare workers. Radiation exposure refers to when a patient is exposed to the radiation, but the source of the radiation or the radioactive material is not associated with the patient. When a person is exposed to radiation, the energy penetrates the body. For example, a person gets an X-ray. He or she is then exposed to radiation. These patients can become ill from the radiation exposure, but importantly, they do not represent a risk to healthcare workers because there is no radioactive material on them. This is in contrast to radiation contamination. Radioactive contamination can occur if radioactive materials are released into the environment as a result of an accident, an event in nature, or an act of terrorism. These patients will have radiation exposure as well, but importantly, these patients can expose healthcare workers as the radioactive material is associated with the patient at the time of presentation. Radiation contamination comes in 2 forms. First, external contamination occurs when radioactive material in the form of dust, powder, or liquid comes into contact with a person's skin, hair, or clothing. In other words, the contact is external to the person's body. The other type is internal contamination, when a person swallows or breathes radioactive material, or when radioactive materials enter the body through an open wound or are absorbed through the skin. Some types of radioactive material stay in the body and are deposited in different body organs. Other types are eliminated from the body in blood, sweat, urine, or feces. So where do these sources come from? So some examples here, americium can be found in smoke detectors. Tritium can be found in some types of lights. Nuclear medicine and imaging is a common place to find radioactive materials. You can see here, thallium, for example, is commonly used. Radon, most people have heard about, can be located in the dirt, soil, and can be an exposure in homes. Cesium-137 is a common source of radioactive material because it's the source for radiation therapy. It was also notably the source for the Chernobyl incident. And then finally, in nuclear reactive plants or fission plants, you can see iodine as a common source. As you can imagine, these sources can impact a small number of people if the situation is contained quickly. However, large-scale radiation disasters can impact hundreds or even thousands of people if the device is able to spread radioactive material. While these scenarios are unlikely, it's important to discuss and recognize them because they have implications for healthcare worker safety and patient management. So the first type of device that I want to talk about is the radiological exposure device, or RED. Radioactive material or an object containing radioactive material can expose people to radiation without their knowledge. Such objects are called REDs, or hidden sealed sources. REDs may be hidden in public places, such as under a subway seat, in a food court, or in a busy hallway. People who sit near or pass close to the RED may be exposed to radiation. These people will have radiation exposure, but no contamination. Next is the radiological dispersal device, or RDD, also called a dirty bomb. A dirty bomb is a mix of explosives such as dynamite and also contains radioactive powder or pellets. A dirty bomb is different than an atomic blast, just given the size. When the bomb explodes, the blast carries radioactive material into the surrounding area. This has the potential for both radiation exposure and contamination. Finally, the improvised nuclear device, or IND. An IND is a type of nuclear weapon. When an IND explodes, it gives off 4 types of energy: a blast wave, intense light, heat, and then radiation. The bomb dropped on Hiroshima, Japan at the end of World War II is an example of an IND. This has both the potential for radiation exposure and contamination, although the extent and scope of damage is much more extreme. So what happens if you receive a patient from a dirty bomb, for example? Because dirty bombs have the potential for contamination, PPE is a must. PPE will be needed in any case where the patient is contaminated or if circumstances are unclear and there is a potential for contamination. Because patients with radiation exposure do not have radioactive material on them, healthcare workers do not need PPE. PPE can protect against internal and external contamination via inhalation, ingestion, absorption, and through open wounds. Notably, PPE cannot protect against exposure from high-energy, highly penetrating forms of ionizing radiation associated with most radiation emergencies at the site. PPE should include a personal radiation dosimeter whenever there's concern about exposure, which can tell the individual what amount of radiation they're currently being exposed to. The recommended PPE for any potentially contaminated patient would be at a level C, which includes a hooded chemical-resistant clothing, face shield, gloves, boots, and a respiratory PPE including a full face piece air purifying respirator with a P100 or HEPA filter. If there is concern for contamination, the first step in management is decontamination. This can be accomplished by simply removing the patient's clothes and removing any evidence of radioactive material with soap and water. A Geiger counter can be used to identify areas of contamination and if the decontamination efforts have been sufficient. From there, you would triage and manage any traumatic, medical, or burn presentation as you normally would. As with any decontamination effort, patients should be first stabilized prior to decontamination. The main medical consequence that will be most pertinent to clinicians is going to be acute radiation syndrome, which occurs whenever a patient has a significant radiation exposure. Initial symptoms of ARS may include nausea, vomiting, headache, and diarrhea. These symptoms start within minutes to days after exposure, can last for minutes up to several days, and may even come and go. This is called the prodromal phase. After these initial symptoms, a person usually looks and feels healthy for a period of time. We call this the incubation phase, and it can last for days to weeks. The onset or manifestation phase is the most serious phase of acute radiation syndrome. The severity and organ system involved depends on the radiation dose. These symptoms include loss of appetite, fatigue, fever, nausea, vomiting, diarrhea, and possibly even seizures and coma. This seriously ill stage may last for a few hours up to several months, and we'll discuss this in the coming slides. Finally, people who receive a high-dose radiation dose can also have skin damage. This damage can start to show within a few hours after exposure, or it may be delayed for several days. It can include swelling, itching, and redness of the skin, like a bad sunburn, or may be more severe and include blisters and ulceration. So who will get acute radiation syndrome after a radiation event? There are two prognostic tools that can be useful to clinicians. First, the time to vomiting. This is an inverse correlation of the time to vomiting and the radiation dose. The higher the dose, the sooner the vomiting ensues. You can see here from this chart that lethal doses of radiation that are over 8 grays, you'll have patients who will have vomiting less than 10 minutes from the radiation exposure. If the vomiting occurs within an hour, that usually is around 4 to 6 grays of radiation. We would call this a severe radiation exposure. And for patients who come in, let's say they vomited 2-3 hours after the radiation exposure, we think this will have less than 2 grays of radiation, and we would call these patients mild in terms of their risk or their prognosis. The other tool is lymphocyte depletion kinetics. This takes a little more time over the course of 1 to 2 days to get the necessary information. The rate of decline of the absolute lymphocyte count is directly related to the radiation dose. The higher the dose, the faster the lymphocyte count will decrease. Notably, a 50% decline in absolute lymphocyte count in the first 24 to 48 hours predicts a potentially lethal radiation exposure. As I mentioned previously, the manifestation phase is the most serious phase of acute radiation syndrome. The severity and organ system involved depends on the radiation dose. At the lower end, patients may develop the hematologic syndrome, which occurs when patients are exposed to 1 to 2 grays of radiation. They develop essentially a pancytopenia. Treatment is supportive. Some clinicians will provide G-CSF for an ANC less than 500. As the radiation dose increases, patients may develop the gastrointestinal syndrome. This is different than the GI symptoms associated with the prodromal phase. It occurs with exposures greater than 5 to 6 gray. Patients develop a loss of the GI barrier, sloughing of mucosa, dehydration, necrosis, melena, and then ultimately sepsis. Many clinicians will administer fluoroquinolones for 2 to 4 days after exposure to prevent infection. There is some discussion about providing serotonin receptor antagonists prophylactically, and then finally providing loperamide to control diarrhea, but the treatment is largely supportive for this. Finally, on the most severe end is the neurologic syndrome. This occurs with a radiation dose greater than 8 to 10 gray. Patients will very quickly develop fever, hypotension, gastrointestinal symptoms, seizure, coma, cardiovascular collapse, and then death. This by far is uniformly fatal if patients present with this syndrome. The treatment here is supportive care. Finally is the cutaneous syndrome. This is different than acute radiation syndrome, but it's an important corollary, which is that patients who develop this syndrome have local exposure, not whole body exposure. You need whole body exposure for acute radiation syndrome. Cutaneous syndromes usually are the result of local exposure, most likely a beta source. Patients may get transient erythema, and then the burns develop over the course of several days to weeks. One important treatment modality to mention is chelation, which is only for particular radionuclides in the setting of internal contamination. So DPTA is a chelator that may be amenable for plutonium, americium, or curium. And then Prussian blue may be used for cesium and thallium. Chelation in general is an uncommon scenario, so consultation with a medical toxicologist or your regional poison control center will be needed. One specific radionuclide to mention as well is iodine. So potassium iodide, or Ki, is a type of iodine that is not radioactive and can be used to help block one type of radioactive material, which is radioactive iodine 131, from being absorbed from the thyroid. For Ki to work, a person must take it before or shortly after exposure to radioactive iodine. When a person takes the right amount of Ki at the right time, it can help block the thyroid from absorbing radioactive iodine. This happens because the thyroid has already absorbed the Ki and there's no room to absorb the radioactive iodine. Again, these types of maneuvers are going to be uncommon or unusual, and a medical toxicologist or the regional poison control center will be able to assist. With that, I'll mention some additional resources that can be helpful. First is the CDC Radiation Emergencies website. It has great information for clinicians specifically, about what to do in a radiation emergency or disaster. Second is REACTS, which is the Radiation Emergency Assistance Center and Training Site. It's a world-renowned U.S. Department of Energy asset, and they assist specifically with emergency preparedness and subject matter expertise on the medical management of radiation incidents. The Radiation Injury Treatment Network is a group of hospitals with specific capabilities in managing radiation patients, and specifically bone marrow transplants if needed. As I mentioned previously with the chelation efforts, the Regional Poison Control Center is available with medical toxicologists that can help guide diagnostics as well as indications for therapy in that domain. And then finally, associated with the RDHRS, we are available to help with subject matter experts in this area when it comes to large disaster radiation events, specifically with patient care. And with that, I thank you for your time.